Good afternoon, everyone. Thank you, Vinkar, for giving me this opportunity. And Sujata has put me a tight spot, debating with Dr. Mamas, a great academician, international cardiologist, and internationally renowned key opinion leader. So I wanted to approach Dr. Mama's debate in two ways. There's only my strategy of winning the war. The first thing is to get your support. Next slide, please. Next. Okay. So, how many of you do imaging as Dr. Mamas was telling you in 100%? Except Dr. Mamas, nobody would. Natalie, do you imaging in 100%? Over 75. So, how many of you at least in 25% of the cases? Oh, that's good number. I like it. So, I have you on my side. The second thing is, I want to say, I disagree with Dr. Mamas. I have to say first, I agree with him. So, let's look, that's what Dr. Mamas was telling you, that it's not a good idea to ride the bicycle without lights in the night. So, if you have a light, you can, as Dr. Mamas was telling you, that you can have calcium nodules, the road, and you can get over them very well. But he has shown you that number of RCTs and registry data has shown improvement in the MACE, meta-analysis, death, all-cause death, cardiac mortality, stent thrombosis to the extent of 52%. But in your routine practice, you encounter a patient like this who has a limiting angina, not ACS, and this straightforward lesion. Do you think of doing imaging for this case? Each case is different. Similarly, I don't need lights to ride in the broad daylight. And even in UK, the legal requirement to use lights only between the night, not in the daytimes. So the potential indications or what we have in these trials is we have seen a mixed bag. But the patient comes to you at few of these indications, clinically at the CKD or ACS, anatomically these various lesions where potential benefit with intracoronary imaging is there, or procedural with PCI with DCB. So you can use a different modality as an IVUS or OCT depending on the anatomical considerations and also the clinical consideration. You can use either of these modalities. One of the emerging modalities is the CT, where you can do a planning even before doing a PCI, to improve the cath lab. So I will address this in the next 10 minutes. What is the evidence? What is the real world? What are the roadblocks and what are the guidelines? The evidence. The CTO, we have evidence. There is an RCT showing definitely IVUS guided PCI decreases cardiac death as well as MACE. In left main disease, this is a meta-analysis of 18 trials which has shown a significant decrease in target lesion failure, all-cause death, as well as cardiac death. And that's the optimal trial which was going on, which is presented specifically addressed to the LM disease. And in CKD, the CKD subset in the ultimate trial has shown significant benefit. The benefit in the CKD patients is much more than the patients without CKD. The same results have been reciprocated in the Renovate Complex PCI trial. In the ACS also, you have a definite evidence that image-guided PCI decreases MACE, cardiovascular death, MI, and target visual lesion revascularization. In complex bifurcation, the October trial presented in the ESC 2023 has shown a composite endpoint benefit in complex bifurcation. Not all, complex only, not simple. The long lesions, this is the data from IVUS XPL and ultimate trial. When the lesion is more than 28 millimeters, definitely imaging is beneficial. That's using IVUS. Coming to the calcified lesions, we have seen the use of imaging in the calcified lesions. Every conference you go, you talk about calcified lesions. This is the EAPCA consensus document. It says, you look at it, it says, the best guided by intravascular imaging, only one sentence, that is in the left main disease only. In fact, this consensus document contains a recommendation, an algorithm for doing a PCI in calcified lesions using CT and angiogram, not with imaging. That's the algorithm. And the pre-procedural CCTA, the current CT angiography, if the calcium score is more than 453 or the ARC is more than 220, they recommend using a tool. That is pre-procedural planning using a CT. And coming to the stent failure, you have seen in the morning a live case where imaging is strongly recommended, and this same EAPCA document says, consensus document says that evidence is lacking. There is no evidence in stent failure that doing imaging gives you better results compared to doing not imaging, treating this either stent thrombosis or ISR. In PCI DCB, you look at the endpoints, or starting points, beginning points, or either angiographic, severe stenosis that's relieved, less than 30%, or a good flow, both less than type 2 dissection, or a physiological endpoint, but there is no imaging endpoint. So now, coming back to our indication, we have evidence in CKD, we have evidence in ACS, we have evidence in CTO, we have evidence in unprotected left main, bifurcations, that too complex, long lesions, but the evidence is still to emerge in calcified lesions, stent failure, graft disease, MINOCA, and in PCI with DCB. What is the real world? This is the use in EK. This is from the London registry, which was done long back, and the use is pretty low. But low rates of usage in that, presently it is all over the UK, it is around 25%. Probably Dr. Mama's center, Dr. Mama's may use 100%. How about his other colleagues? Probably it will come to less than that. Even in USA, this is the Medicare data shows very low usage of imaging. The OCT or IVUS, even though the results are better with IVUS and OCT compared to angiographic guidance. Now, this is the recent data where the imaging use has increased in USA, now coming to 15.4%. And in my center, we use, slowly after the COVID, we started using imaging. This last year, our whole group has used 35%. I use around 72%. And the OCT use is more than the IVUS use. IVUS use has been catching up. This is in my center experience. And coming to this point, is the image-guided PCI okay? No. Just using imaging is not the point. So you look at these trials, and this is the randomized control trials done by experts. The achieved endpoints are only in about 50 to 60% of the patient. They have achieved predefined endpoint in just less than 2/3 of the patients. Imaging per se doesn't improve outcomes, but achieving optimal results definitely pays off in showing compared to the optimal result to suboptimal results, either in the ultimate trial or IVUS XPL trial or Innovate Complex PCI trial. What are the roadblocks? High cost, longer duration, reimbursement issues, lack of training, and fear of risk of complications. The guidelines are also very not in favor of that. Either the 2018 ESC guidelines or 2021 guidelines to show that they are a reasonable alternative. They give a 2A recommendation only, not class 1. There is a big push to give the class 1 recommendation of imaging in routine PCI. My take is the coming guidelines are likely to recommend class 1A, only, not all patients, only a select group of population like CKD, CTO, left main disease or acute coronary syndromes. In conclusion, definitely it's beneficial, which has been shown in the meta-analysis presented by Dr. Stone, and it's durable but lacks momentum. RCT evidence is yet to emerge in all the cases. The penetration of ICI in routine clinical practice is low. More training in use and interpretation is the need of the hour, and its use limit the usage of ICI to indication with established evidence. The ongoing trials are optimal in LM disease, in ACS, IVS hip with complex lesions, ISTEMI in ACS, that's the improved trial, and the prevent trial that I mentioned by Dr. Mamas. I don't need lights all the time. Thank you for your attention.